In this third lecture on digestive disorders, I'll be talking about accessory organ disorders. Remember that when we talk about accessory organs, we're talking about those that are involved in digestion in one way or another, but food does not come into direct contact with these organs. So we're looking at the liver, the gallbladder, the pancreas, and the appendix. We know from our recent discussion on accessory organs of the digestive system that the liver, pancreas, and gallbladder, although they play a big role in digestion, they don't come into direct contact with food. The appendix, still considered an accessory organ, is a little bit different because it hangs right off of the cecum of the large intestine, so it can come into contact with food. In terms of its importance, we know it's an immune organ to some extent. It's made up of some lymphoid tissue, but it also has a colony of good bacteria residing within it. And if the large intestine needs to be populated, or repopulated with good bacteria, that can occur because of what we have within the appendix. Now, if the appendix becomes obstructed for some reason, this can be a major problem. And it doesn't take much to obstruct it. And when this happens, when let's say there's a blockage here, it can cause inflammation, and it can become so inflamed that it can burst. And if it bursts, this is where it becomes a major problem. It can lead to what's called peritonitis, or inflammation of the peritoneum. And why that happens is because within the appendix, we have bacteria that's supposed to remain within the digestive tract. And there's also fecal material in here. And if it ruptures, those contents end up within the peritoneal cavity, which can lead to inflammation, could even get into the blood and causing sepsis, which could overall lead to death. Usually the inflammation will begin at that inner layer, the mucosal layer, spreading outward to the submucosa and continuing on from there. Pain is oftentimes in the right lower quadrant, although it can be around the belly button area. It's common for patients with appendicitis to report rebound tenderness, where you apply pressure to the lower abdomen, in particular that right part of the lower abdomen, and when you let go, that rebounding effect can cause pain. Treatment is obviously surgery, ideally removing the appendix before it ruptures. Otherwise, if it does burst, then it needs to be the whole abdominal area is going to need to be cleaned out very thoroughly. Let's look at a flow chart now of the development of appendicitis. I've spoken to some of this already. Initially, there is going to be an obstruction at the opening of the appendix where the appendix is almost sealed off. And this can be because of a tumor growth. It could be by fecal impaction. So somebody that has a poor diet, maybe they're suffering from constipation, or a foreign object of some sort. Kids consume all sorts of things that can end up being passed through the digestive system that can create a seal on the appendix. But in any case, it gets sealed off. Any contents in here can start multiplying. So we can get bacteria multiplying or proliferating because of stagnant contents. The appendix can't drain properly because it's been sealed off, but the mucous membranes are still going to be producing substances. They're just not going to be drained. This is going to cause quite a bit of distension that occurs. So we get swelling, distension, inflammation, overall increased pressure. And you can get to the point where the tissue of the appendix itself is no longer able to get its proper blood flow. So we see ischemia, potentially necrosis, and even rupture. And then rupturing can lead to peritonitis and sepsis, and if it's not taken care of in time, it can lead to multi-system organ failure. But nowadays, that's more uncommon. Okay, we're going to have a look at the blood supply to and from the gastrointestinal tract. So taking a step back a little bit. And we're going to look at the main arteries that supply the GI tract. We can see 3 listed here, and you can also see them listed here. So the heart pumps out oxygenated, nutrient-rich blood through the aorta, traveling down into the abdominal aorta, where we have branches such as the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. And then these will all have additional branches that come off each of them, also traveling to different digestive organs. So that's the arterial supply. That's where these organs get their oxygen-rich, nutrient-rich blood. But after you consume food, so let's start at the level of the small intestine. You consume food, it ends up in your stomach, it ends up then in your small intestine, where you break it up and it's absorbed into your bloodstream. More specifically, it's absorbed into your venous bloodstream. This blood, we don't want it going directly, even though it's nutrient rich, to all of our organs and our cells. What we want is to detoxify it first and clean it. And so nutrient rich blood from the small intestine is going to enter into the hepatic portal vein. And once it's in the hepatic portal vein, it's going to travel to the liver. Hepatic refers to liver. And this blood's going to go through the liver. It's going to be cleaned and detoxified, where it will then leave the liver through the hepatic vein, entering into the inferior vena cava, ending up in the heart, specifically the right side of the heart, where it will then be pumped to the lungs to be oxygenated, return back to the heart, where it's now oxygen rich and nutrient rich, where it can be pumped out via the left side of the heart to the rest of the body to supply all of our organs. Of course, only the digestive organs are shown here. So pertaining to these three major arteries, looking at the next slide, we're going to talk about vascular insufficiency. So the concept of ischemia or reduced blood flow to the gastrointestinal tract. Vascular insufficiency of the GI tract can occur if two of the three major arteries that we just spoke about are blocked. Now, why two and not just one? Well, it's because there's so much collateral blood supply, so many additional branches that supply the cells of the GI tract. Vascular insufficiency can happen to those that have atherosclerosis, so hardening of the arteries, as well as disease of the heart. Some additional common causes, other than what I just spoke of, include shock. Shock is a life-threatening condition that occurs when the body is not getting enough blood flow. And a lack of blood flow to organs mean that those cells are not going to get enough oxygen and nutrients to function properly, and as a result, they can be damaged and even die. So shock happens to really the entire body when it occurs. And then another example is a burst abdominal aorta. So our aorta that comes off the heart travels in a descending fashion through your thoracic region, and then once it's past the diaphragm, it is called the abdominal aorta. And the abdominal aorta the walls can become weak in certain cases, where it starts to balloon and form an aneurysm. It's called an abdominal aortic aneurysm, or a AAA. And if this bleeds, it's going to cause excessive bleeding and blood loss, which can lead to GI tract ischemia. Complications. So obviously, if somebody is experiencing a reduction in blood flow to the gastrointestinal tract, it could lead to necrosis, where you get death of the mucosal layer to start. And if damage continues to progress from the mucosal layer more externally, it can cause rupturing of the GI tract, which we know can lead to peritonitis. It can lead to sepsis. And then in less serious cases, GI ischemia can cause the gastrointestinal tract to not allow for proper absorption or digestion and absorption, which can lead to malnourishment. Remember that after we consume food and it's digested primarily in the small intestine, that the nutrients that are absorbed are going to enter into the portal system. so entering into the portal vein and traveling to the liver where it will be detoxed before it returns to the heart. So in the normal hepatic portal system, we know blood should be able to move properly from the small intestine through the hepatic portal vein to the liver, then leave through the hepatic vein to return to the heart. Now in portal hypertension, the liver is obstructed, leading to an increased resistance. So it's harder for blood to move through or to or through the liver. And this causes an increase in blood pressure within the portal vein. And this is what we call portal hypertension. So blood backs up, and this can cause edema. So if blood can't move through the liver, it's going to back up into the portal system. A common cause of this is a condition that we'll talk more about later called cirrhosis, which is a liver that has been damaged enough that scar tissue forms. And when blood can't move through that scar tissue, it will back up into the portal system. It needs to go somewhere. So because it backs up into the portal system and ultimately can't return to the heart, so much pressure is going to build up throughout these veins that it seeps out of the veins and into the abdominal cavity, leading to a condition called ascites. There's another piece to this puzzle, though. You might recall that the liver produces a protein, a plasma protein called albumin. And albumin is a large enough protein that normally it stays within our blood vessels, and it promotes fluid to stay within our blood vessels. Now, if the liver is damaged, it can't produce the same quantity of albumin, leading to a condition called hypoalbuminemia, so low amounts of albumin in the blood. And so if we have low albumin in the blood, and we know that albumin is going to promote fluid to remain within our blood vessels, then we're going to get even more fluid leaving our blood vessels. So basically the fluid is able to easily seep through the vessel and end up in the abdominal cavity or into the tissues in that area. And this further promotes the development of ascites, which is sometimes described as a beer belly appearance, or it can look like the person is pregnant, as we'll see in the next image. So let's look a little bit more at the potential consequences of portal hypertension. Anytime blood backs up into the venous system, it can cause the venous walls to dilate, leading to what's called varices. So varices can form in a number of different locations, but one example I'm going to give you now is esophageal varices. So if we look at this image, here we have the portal vein that would travel, the hepatic portal vein, to the liver. And if blood can't get through the liver, it backs up into the venous system. And one example where we can see a backup occurring in serious cases is at the level of the esophagus. So here's your esophagus. You can see the varices. They're like varicose veins of the esophagus. And these veins become tortuous and twisted, and they can be damaging to the esophageal tissue. They can also burst as they continue to enlarge, leading to hemorrhaging and even death. And when the blood backs up, the reason that it's backing up into all these different vessels is it just really wants to return to the heart. And so it's trying to find an alternate pathway. And in the process, it can be very damaging to those veins. Another consequence is of the spleen, and an enlarged spleen is called splenomegaly, and that's shown in this area here. Blood backs up into the splenic vein, causing it to dilate and form the varices. You might recall that the spleen is an area where red blood cells, for example, go to die. So an enlarged spleen can affect red blood cell count. The spleen is also involved in immune functions. And so for a variety of reasons, splenomegaly can also be dangerous. We talked about ascites already, which is going to be that swelling of the abdomen due to fluid leaking out from vessels and pooling within the abdominal area. And the two main reasons that I mentioned on the previous slide is that if the liver is damaged and can't produce albumin, then we can't keep fluid within our blood vessels, so it seeps out into the tissues around it. And also that increase in pressure within the portal venous system where blood can't move through the liver and it builds up. That venous backup eventually will increase pressure enough that fluid seeps out of the vessels and into the tissues in the abdominal area. And so you can see that pregnant appearance of the belly or that beer belly description. And the term or the phrase beer belly really does make sense because people that drink a lot of alcohol and have any form of damage to their liver can experience ascites, and they can develop this hard abdomen, which is a medical concern. The last example of a consequence of portal hypertension is hepatic encephalopathy. Encephalopathy refers to the brain. So this is a brain condition that results from a liver condition. And a variety of abnormal central nervous system changes can be evident, and this is thought to be due to the accumulation of ammonia, which is a byproduct of protein metabolism, and other toxins as well. So accumulation of ammonia and other toxins. And why do they accumulate within our blood and then end up in our brain? Well, if our liver cannot detoxify our blood properly, then those toxic elements remain in our blood and they travel to the brain and cause damage. So this would be more common in more chronic liver disease states. We're going to have a little bit of a closer look at the development of ascites and the many different variables that contribute to it when somebody has cirrhosis, which we know is the scarring of the liver that we'll talk more about in a bit. And we know ascites is the accumulation of fluid within the peritoneal cavity. The first thing that we'll look at is an increase in lymph production that is quite common in patients with cirrhosis. The liver is actually a major contributor to the production of lymph. And what's seen initially is as the pressure increases within the liver, there is an increase in production in lymph. And too much lymph production, too much fluid is going to contribute to the development of ascites. We've spoken about portal hypertension already and how when there is too much pressure within that portal system, it's going to cause fluid to leak out of the vessels, leak out of the capillaries, and we can more appropriately call that an increase in capillary filtration pressure. So this means that fluid moves out of the capillaries, out of the vessels, and into the tissues, leading to ascites. We also know that if the liver's damaged, the hepatocytes are not going to be able to function as normally as they should. And so one of the events that we'll see is a reduction in the production of albumin, that protein that keeps fluid in our vessels. And we call that more appropriately oncotic pressure. Oncotic pressure is the pressure created by proteins within our vessels that keep fluid in our vessels. If we have a reduction in albumin, we're then going to have a reduction in the pressure that is normally caused by the protein albumin in the vessels, which is going to lead to fluid leaving the vessels as well, because albumin we know is designed to keep fluid in the vessels. So we have this reduction in plasma volume because it's leaving the vessels and going into the tissues. And so our body will initially try to compensate for this by stimulating a system that normally helps us retain more fluid. Remembering back to normal urinary system anatomy, where you would have learned about renin, aldosterone, and antidiuretic hormone, which will work to try to keep fluid within our blood vessels. They will stimulate our kidneys to hold on to more fluid in order to increase our blood volume. But the cycle just continues, and we're trying to bring in or hold onto more water, which ultimately continues to leave our vessels into the tissues, causing ascites. And these events will also be seen when the hepatocytes, or the cells of the liver, are failing, altering normal metabolic processes can stimulate this system. So you can see it's really a vicious cycle. We're going to talk now about jaundice, more appropriately known as icterus, and this is the yellowing that can be evident in the skin and eyes and some mucous membranes of people that have a liver condition or poor liver function. Remember that our red bone marrow is going to produce red blood cells, among other blood cells. The red blood cells enter our blood, they mature, and once they reach about 120 days, or if they're injured or abnormal, they're going to be broken down by macrophages in the spleen and in the liver. And when they're broken down, when red blood cell destruction occurs, we're going to reuse some of the components and discard of others. So hemoglobin is a component of red blood cell, as we know, that's going to be broken down by macrophages into its two main components, heme and globin. Globin is going to be broken down into amino acids, which we reuse in the body to make proteins. The heme portion is going to be broken down into biliverdin, this is really a free bilirubin, and iron, and then we'll reuse the iron to make more red blood cells down the road. Now this biliverdin, we need to be able to discard of this. And so we end up with what's called unconjugated bilirubin. Unconjugated bilirubin is lipid soluble. And if we want a substance that's lipid soluble to travel within our plasma, which is primarily water, it needs to have a carrier because fat and water don't mix. And albumin is that carrier. So albumin will bind with unconjugated bilirubin, bringing it to hepatocytes in the liver so that we can conjugate it. So unconjugated bilirubin binds with albumin, travels to the liver, and the liver will add glucuronic acid to the unconjugated bilirubin, conjugating it. And now it is a water-soluble substance. And what we can do with it at this point is empty it into our bile channels. And eventually, this bilirubin, this conjugated bilirubin, will be part of our urine and part of our feces. But if the liver is damaged and it's unable to conjugate bilirubin, really preparing it to be properly excreted in our body, then it's going to build up into our tissues, build up in the skin and the eyes, causing a yellowing, which is the icterus. Now this increased amount of bilirubin in our blood that is not properly being excreted is more appropriately called bilirubin-emia, hyperbilirubinemia, an increase in the amount of bilirubin in the blood, depositing itself into tissues, causing yellowing of that tissue. There are three types of icterus, and what I mean by that is there are three main events that can occur that can lead to the formation of hyperbilirubinemia and therefore jaundice or icterus. We're going to look at obstructive jaundice and hemolytic jaundice. Obstructive jaundice has two types, either extra or post-hepatic obstruction or intrahepatic obstruction. So what does this mean? With extra or post-hepatic obstruction, we're talking about an obstruction outside the liver, more specifically blocked bile ducts. Remember our bile ducts here. Remember that the liver produces bile, and that bile needs to leave the liver and end up in our gallbladder, and then eventually end up in our intestinal tract. One of the components of bile is bilirubin. And so if there's a blockage here preventing that normal bile-containing bilirubin from leaving the liver, then it backs up and the bilirubin ends up being returned to the bloodstream, putting that person in a state of hyperbilirubinemia, and then that bilirubin can deposit itself into tissues, causing jaundice. So that's outside of the liver, the obstruction. We can also have obstructions within the liver, so it's called intrahepatic. Intra means within. And the best example here is cirrhosis, which we just spoke about. This is a problem with the liver where there's damage of the liver cells acting as an obstruction. If the liver is damaged and full of scar tissue, it should make sense to you that substances won't be able to move through the liver properly. So the damaged liver cells and the damaged tissue around them act as the obstruction. There's also hemolytic jaundice. This has to do with either excessive breakdown of red blood cells, so that's hemolysis. And hemolysis we know occurs normally in the liver and in the spleen, but if it occurs at too fast of a rate, then we can properly break down and dispose of the components, then it can lead to a state of hyperbilirubinemia and cause jaundice. In other cases, if somebody has maybe multiple hematomas in their body that get broken down, we may have too much of the waste product than we can properly dispose of, leading to hyperbilirubinemia. And so this is called prehepatic jaundice. It's occurring before the liver is actually going to be conjugating the bilirubin. This slide summarizes much of what I've already spoken about with just a little bit more detail. We know that jaundice can be caused by a problem within the liver, intrahepatic, outside the liver, extrahepatic or posthepatic, and it can be caused by excess hemolysis of red blood cells. So if we look at intrahepatic, some sort of problem within the liver, so the liver cells can be damaged, you can even have obstruction of some of the components of our bile producing system within the liver. In any case, the liver is unable to properly conjugate bilirubin. And so what we end up with is an excess in the amount of bilirubin in the blood. Although there's going to be a lot of the unconjugated bilirubin, there will also be some conjugated. With extrahepatic, there's a problem just after the liver, and that is usually involving the bile ducts that are obstructed in some way. A common obstruction are bile stones. So these are stones that have formed out of bile that get stuck somewhere in that duct pathway. And that prevents the bilirubin that has been conjugated by the liver from actually getting into our digestive tract so that we can excrete it. So we make the conjugated bilirubin, we just can't get rid of it and dispose of it. And so it's going to end up backing up into the liver and end up backing up into the bloodstream as well. And so this leads to high levels of conjugated hyperbilirubinemia in the blood. What's interesting is that bilirubin will give our stools their dark color. And if we're not able to properly take this conjugated bilirubin, put it into our intestinal tract so that it can become part of our stool, our method of excreting it, the person's stools will be lighter in color. Now, because of this state of hyperbilirubinemia, we know we're going to end up with jaundice. But what's also important to note is that we're going to have an excess in the amount of bilirubin in our urine. Now, why is that? Well, remember that conjugated bilirubin is water soluble compared to unconjugated bilirubin, remember, is lipid soluble, and it required albumin to initially travel within our blood. And that's because our blood is made up of a lot of plasma, which is primarily water. And so this conjugated bilirubin that's sitting in the blood will end up traveling to our kidneys and become a part of our urine. Next up is the hemolytic form, which we know can occur if there is excessive breakdown of red blood cells, causing us our liver not to be able to conjugate all of that excess bilirubin, and so the excess ends up in the bloodstream. and this would be primarily unconjugated, leading to jaundice. So an important note to make is that with extra or post-hepatic obstructive jaundice, this is where we're going to primarily end up with conjugated hyperbilirubinemia, compared to the other two forms where we will primarily end up with the unconjugated unconjugated bilirubin in the blood. And as you're studying, just make sure you note that on this slide I am talking about intrahepatic first, whereas on the previous one it was listed as extrahepatic, so make sure you don't get confused with that. And the final thing to mention about this topic is that clinically you can look at a person's bilirubin in their blood and look at the concentration of conjugated versus unconjugated to gain an idea of what type of obstruction might be present or what condition might be occurring. So again, if we're seeing that the conjugated bilirubin is high within the blood, then we're going to consider extra or post-hepatic obstructive jaundice. If we're seeing primarily unconjugated, we're looking at more of a hemolytic cause or a intrahepatic cause. And then also somebody that has excess bilirubin in their urine, that could indicate extrahepatic obstructive jaundice as well. So now we're moving on to a different topic, looking at viral hepatitis. Itis is inflammation, so this is inflammation of the liver caused by a virus. And the hepatitis strains primarily affect the liver. That's why they get the term viral hepatitis. Speaking very generally, when we look at viral hepatitis, and we'll look at some of the different strains on the next slide, but speaking generally, we see three phases with viral hepatitis. The first one being the prodromal or pre-icterics. This would be prior to the yellowing of the skin. This phase will occur 2 weeks after somebody has been exposed to the virus, and this is where they'll have signs and symptoms that really precede the condition, and they're really generalized, non-specific symptoms: fever, malaise, myalgias. The term malaise refers to just a general feeling of discomfort, feeling unwell, but not being able to pinpoint exactly why. Whereas myalgia refers to muscle aches. The icteric phase, it occurs 3 to 4 weeks after the exposure, and it can last anywhere from 2 to 6 weeks. And it will include jaundice, liver pain, vomiting, fatigue, and itching. And so itching is due to the hyperbilirubinemia. When the bilirubin deposits itself in the skin, it makes the skin yellow, but it also makes the skin itchy. So these people will have sort of generalized itching throughout their body. The recovery phase, also sometimes called the post-icteric phase, this is when a lot of the symptoms actually diminish, even though the liver can still be enlarged and still be tender. This person's liver function tests could actually return to normal. But there are cases where chronic hepatitis will occur, and that's more common with certain strains. So let's have a look at some of those strains. There are many different strains of viral hepatitis, including A, B, C, D, and E, but we are going to speak about some of the main characteristics of A, B, and C. A is more commonly referred to as infectious viral hepatitis. It's more typically seen in developing worlds where there's issues with food and water contamination, and as well just unsanitary conditions. This can be spread through the oral route, so consuming food or water that's contaminated, or the fecal oral route, which is where people maybe not cleaning their hands properly when maybe preparing food or touching surfaces. So it really can become an epidemic if there is no good clean water source and a lot of contamination present. Type B is oftentimes called the serum version of viral hepatitis because it's transmitted through the serum. Transmission through contact with infected blood, body fluids, or contaminated needles is a common reason for somebody becoming infected with type B. It can be prevented by the Hep B vaccine that exists. Somebody can also be a carrier, and that's important. You can be a carrier of type B, but not show any symptoms. And when this happens, it means you could pass it on without even knowing that you have it. 30% of people with viral hepatitis will end up with a chronic condition. And so that's also an important component. So again, type B, carrier states are possible, and 30% could end up with a chronic state of viral hepatitis. And then type C is a most commonly occurring post-transfusion or with IV drug use. 50 to 80% will end up with chronic hepatitis. So what we can really take from this is that type B and C, there is a risk, much greater with C, of developing chronic hepatitis, where with type A, it is much less likely. So people can recover. Now on to talking about cirrhosis, which we've already talked about, but just a little bit more information and a reminder of some important parts. Cirrhosis is a liver condition. It is a state where somebody ends up with scarring of their liver. And once somebody has the diagnosis of cirrhosis, it is irreversible. It's an irreversible inflammatory state that will disrupt the function of the liver, but it will also disrupt the structure. We know that the liver is one of our organs that can regenerate, but if it's destroyed by pathological conditions, it's not going to regenerate properly. It needs healthy cells to regenerate. And with cirrhosis, the majority of the liver is affected, so it can try to regenerate, but it's not regenerating healthy cells. And it can impact the structure of the liver, remembering back to the unique design of the liver that's important to its function, and we know structure and function are highly related. Very common cause is alcohol. So most people with cirrhosis have had issues with overconsumption of alcohol in the long term. Alcohol-induced cirrhosis is more likely to cause a type of cirrhosis called micronodular. Other causes of cirrhosis include viral hepatitis, particularly B and C, because we know that those are the types that can lead to chronic infection in some people. So B and C then, although they can cause micronodular cirrhosis, are more likely to cause macronodular cirrhosis. Normally we should have these nice lobules within the liver, but as it regenerates instead, in cases of damage, we end up with micronodules and macronodules. So let's look at the pathway with somebody who has chronically ingested alcohol that has damaged the liver. So the liver cells are damaged by alcohol oxidation over time. These hepatocytes try to regenerate, but instead of forming lobules, they form nodules. The nodule formation is going to lead to fibrosis, so we end up with fibrotic tissue that causes scarring. Between the nodules, we'll see deposition of collagen, hardening the liver. So we can see the collagen deposition in between here. The liver becomes less plump, so it's smaller than normal, and liver function greatly reduces. So we're talking about so many different functions now that our body cannot be dependent on. Formation of proteins such as albumin, detoxing our blood. And now a lot of the nutrients from our digestive tract can't properly get through the liver to even get to our heart so that it can become a part of our normal circulation. Now we have what's called an intrahepatic obstruction. We can't get blood from that portal vein back to the heart or to the heart. And we end up with a variety of consequences of portal hypertension that we've already talked about, esophageal varices, splenomegaly, and ascites. Blood flow to the liver will be compromised, hypoxia, leading to necrosis of the liver, and the state of cirrhosis. In the initial stages of increased alcohol consumption over time, a person can develop a fatty liver. And the fatty liver occurs because the proper metabolism of your liver is compromised. And so we end up with the buildup of fat within the liver because we're not properly breaking it down. We talked about this in one of our much earlier lectures. And when we have a fatty liver, full recovery is possible. So when somebody's diagnosed with a fatty liver, if they abstain from alcohol, they can have a full recovery and the liver can properly regenerate. Liver fibrosis, once this starts, there can be recovery enough that the liver can still do much of what it needs to do, but any scar tissue that is formed will remain. Once somebody has cirrhosis, and we looked at this pathway on the previous slide, the damage is irreversible and the person will need a liver transplant in order to survive. But how long a person can survive, what their prognosis is with cirrhosis will be dependent on a number of different factors. Okay, let's put our talk about cirrhosis into this flow chart and adding in a couple of additional items. The state of liver inflammation, regardless of what it's caused by, can lead to liver necrosis. And liver necrosis, once the tissues start to die, can lead to the formation of fibrous tissue and scarring. But let's look at some additional consequences that we'll see. If the liver is not functioning properly, we know that we're going to have a reduction in the metabolism of bilirubin, which we know is normally conjugated at the level of the liver, leading to hyperbilirubinemia and jaundice. We also know that if the liver is damaged, less bile containing bilirubin is going to end up in our gastrointestinal tract, and that can lead to light-colored stools. Now, a new piece of information. The liver is the area where vitamin K is produced, and if the liver is damaged and can't produce vitamin K, then bleeding is more likely to occur. And the reason for that is because vitamin K is very important in the clotting process. We spoke about how sometimes bilirubin, when the liver is damaged, can end up in the urine, and that's called urobilinogen. And because of the pigments found in bilirubin, it can lead to darker urine. We also know that the liver is going to be what contributes to some of the metabolism of nutrients. And so if it's damaged, we're not going to be metabolizing nutrients properly. Our liver is also a source of glycogen, which is stored glucose. So if our body needs more glucose, we can break it down to put it into the blood. But if we can't do that properly, we can end up in the state of hypoglycemia, not enough glucose in the blood. We also know that the liver produces plasma proteins such as albumin. And if we don't have enough albumin in our blood, and we can't therefore keep fluid in our blood, it leads to ascites, and it can lead to swelling elsewhere as well. If the liver is failing, we talked about hepatic encephalopathy, so a buildup of toxins within our blood that can travel to the brain and cause central nervous system functions and could, in progressed cases, cause death. A fibrotic and scarred liver is most certainly going to induce portal hypertension. We've talked about many of the effects of portal hypertension, so ascites and other swelling. We talked about splenomegaly and varices, but we're going to go just a little bit into more detail here. When the spleen is enlarged, it can cause changes in the way that blood cells are processed, leading to anemia, a reduction in red blood cells, thrombocytopenia, a reduction in the amount of platelets or thrombocytes, clotting cells, and a reduction in white blood cells. In terms of varices, thinking back to that diagram that we spoke about earlier, we spoke about esophageal varices when portal hypertension occurs, and that backup of blood into the venous system can also cause varices elsewhere in the body, including hemorrhoids and superficial abdominal veins called caput medusa. And if I go back to this slide here, you can see the caput medusa. You can also see the hemorrhoids, the enlarged esophageal veins, and the enlarged splenic vein that can lead to splenomegaly. And finally, when there is damage to the liver, there are a variety of different tests that can be done to determine a person's liver function. And what will oftentimes be seen in cases of liver damage is elevation in AST and ALT, which are liver enzymes, alanine aminotransferase and aspartate transaminase. There'll also be elevated bilirubin, which we've talked about, hyperbilirubinemia. There's going to be hypoalbuminemia, so low amounts of albumin, which we know is because the liver can't produce albumin when it's damaged. There's going to be prolonged prothrombin time. Prothrombin is relating to clotting time, and that is related to a vitamin K deficiency. So what we've talked about are just some of the events that we can see occurring when the liver is damaged, and I'm sure you realize now, if you haven't already, how important the liver is in normal bodily functions. Our final topic on digestive disorders is cholelithiasis. And cholelithiasis just refers to the formation of gallstones, so stones within the gallbladder. And these stones are largely formed by cholesterol. Now, when somebody suffers from gallstones, it's going to be some sort of impairment in the normal metabolism of cholesterol, bilirubin, and bile acids. Now, just because somebody has gallstones doesn't necessarily mean that they will end up with an obstruction or inflammation, but it could occur. So the term cholecystitis refers to inflammation of the gallbladder due to oftentimes the presence of gallstones, and this can be a very painful condition. If we get blockage of the cystic duct, so let's look at this image here. The liver would be up here. Liver produces bile. It ends up in our gallbladder. Then it would leave the gallbladder and enter into the small intestine. So this cystic duct here off of the gallbladder, if it's blocked, let's say there's a gallstone that's blocking it, it can cause the gallbladder to increase in size. It could, in rare cases, cause the gallbladder to rupture. Now, on the other hand, if there's blockage of the common bile duct, which is right here, then what this is going to cause is post or extrahepatic jaundice, which we've talked about already. We're unable to get that bile into the intestinal tract, so it backs up and ends up in the blood. If there's blockage of the hepatopancreatic ampulla, also known as the ampulla of Vater, that's further down here, then this can also, it's just a little bit more distal, this can also lead to post-hepatic jaundice. And because of the commonly shared duct with the pancreas, it can also lead to inflammation of the pancreas. Now, there are a variety of different causes of the formation of gallstones, but one cause can be a diet that is too high in fat, because we know that cholesterol is a fat, and cholesterol stones, or stones made of cholesterol, are the most common cause of gallstone formation. Next up, I'm going to talk about pancreatitis which is inflammation of the pancreas. Looking at these images, here we have a normal pancreas and an inflamed pancreas where you can see lots of redness and hemorrhaging evident. Now, normally the pancreas is going to be producing digestive enzymes. So that's really the exocrine function of the pancreas, remembering that it also has an endocrine function in producing hormones such as insulin and glucagon. Now, the enzymes, the digestive enzymes that contribute to digestion that are produced within the pancreas are inactive, and they only become activated once they reach the duodenum, or the first part of the small intestine, where they will contribute to digestive processes. But with pancreatitis, the enzymes get activated inside the pancreas, so inside the cells or just outside the cells that make up the pancreas, and they injure the pancreas. So really, there's a lot of chemical damage that's occurring. This flowchart shows some of the major events, and at the top we can see acinar cell injury and duct obstruction as two of the main predisposing events that can lead to pancreatitis. Acinar cell injury, when we talk about the pancreatic acinar cells, these are the functional units of the pancreas in terms of its exocrine function, where these cells are what produce digestive enzymes and then secrete them so that they can reach the small intestine. So injury to these cells can lead to activation of the enzymes that are found within and just outside of the cells inside the pancreas, leading to that chemical damage. Duct obstruction is another method by which pancreatitis can occur. So some sort of obstruction of a duct that doesn't allow for the normal movement or flow of the enzymes that were produced. And this can lead to edema or swelling. It can impair blood flow, cause ischemia. Common events that can occur anytime there is an obstruction to the normal flow of a substance. These events can also damage the acinar cells of the pancreas, but in both cases, the main event that occurs leading to the pancreatitis is this activation of the enzymes just inside and outside the cells of the pancreas. Two examples shown here of enzymes that can be activated within the pancreas include trypsin and lipase. Lipase, ACE referring to enzyme, the lipe part referring to fat. This is an enzyme that breaks down fat, and it's oftentimes called pancreatic lipase because it's produced in the pancreas, and it will be transferred to the small intestine where it will participate in the hydrolysis and digestion of fat and cholesterol, that sort of thing. When this enzyme becomes activated inside the pancreas, it can actually cause fatty cells within the pancreas to become damaged, leading to fat necrosis. Trypsin is an enzyme that helps us digest proteins. So it's going to break down proteins that are present within the small intestine. Sometimes you'll hear this enzyme referred to as a proteolytic enzyme or proteinase. The pancreas actually produces what's called trypsinogen, which is the inactive form of trypsin. And so we don't want trypsin to be present within the pancreas because it can start digesting the pancreas, essentially. Other enzymes can also then be activated within the pancreas, such as chymotrypsin, phospholipase, and elastase, just very destructive enzymes that can lead to further cell injury, breaking down really the structure of the pancreas, leading to swelling, formation of clots, bleeding, and even necrosis. This will coincide with inflammation. An inflammatory response will occur, and that's the itis component of pancreatitis. And this involves the release of cytokines that are pro-inflammatory and complement activation, which is also pro-inflammatory. Now, these events can worsen, and in worst case scenarios can lead to events such as shock, and others as listed here, such as systemic inflammatory response syndrome. I just wanted, though, to bring your attention to shock. And the other concern would be that Bacteria that are present within the intestinal tract due to the pancreatitis and the impairment in normal flow of substances can actually translocate and enter the blood and cause sepsis or bacteremia. And abscesses and cysts can form as well within the pancreas. And so obviously, treating pancreatitis in the early stages will have a better outcome than in the later stages. Next up is pancreatic cancer, which starts in the exocrine part of the pancreas. And so you should make note that this type of cancer is an adenocarcinoma, so cancer of the glandular tissue. The most common location that I need you to make note of is the head of the pancreas. So here's the head of the pancreas and here's the tail. So you can see the cancer here. And the problem with this location is it can oftentimes be hidden behind other organs. And if it's hidden, then it's more difficult to find in the early phases, even if somebody does have symptoms or maybe they have pain in this area, it can hide. It can act as well as an obstruction, and you can probably see that here. It can obstruct the normal flow of fluid into the duodenum, fluid and the enzymes associated with it. Unfortunately, this type of cancer is oftentimes diagnosed in the later stages, going back to being difficult to diagnose. This cancer can, in addition to acting as an obstruction, and I'll just go back here to remind you that pancreatitis can be caused by a duct obstruction, so somebody with pancreatic cancer can also have pancreatitis if that cancer is acting as an obstruction. The tumor can invade and destroy the tissue that makes up the duodenum and any other structures that are near it. A common area of injury is the biliary duct that you can see in green. And this can lead to what's called obstructive jaundice. And that's one of the first signs of pancreatic cancer. We can't get the normal flow of bile through this duct, and so it backs up, leading to a type of icterus called obstructive icterus or obstructive jaundice. Pancreatic cancer is more common in men over the age of 50, but it can inflict others as well. Usually by the time it's diagnosed in its later stages, the prognosis is poor. Alcohol and smoking are thought to be causes of both pancreatitis discussed previously and pancreatic cancer, but there are other causes that exist as well. All right, that is the end of this lecture. Thanks for your time.